This presentation will review the exemplars of seizures and headaches within the intracranial regulation concept. Our learning objectives are to identify the various types of seizures, recognize risk factors for seizures, use the nursing process as a framework for care of the client with seizures, and then identify causes, clinical manifestations, client education, and nursing management of clients experiencing headaches. Seizures are an abrupt, abnormal, excessive, and uncontrolled electrical discharge of neurons within the brain that cause alteration in level of consciousness and or changes in motor and sensory ability or behavior. In the concept of intracranial regulation, this is one of those categories that falls under the neurotransmission because it has to do with the firing of the neurons. There are classifications of seizures we need to be aware of. The first classification has to do with where they start in the brain. So if it's a generalized seizure, that's affecting both sides of the brain, both cerebral hemispheres. And if it's a focal seizure, that's one that starts in just one cerebral hemisphere or the other, not both. There are 5 types of generalized seizures that we're going to review on this PowerPoint. Again, involves both cerebral hemispheres. It can start with an aura, which can be a smell or something they hear. It can even be an emotional feeling. The tonic-clonic seizures. So before we go into that, I want you to realize that clonic means uncontrolled rhythmic jerking, and tonic means stiffening or becoming rigid. So someone who has a tonic-clonic seizure begins with a few seconds of that tonic episode where their body becomes real rigid and they have a loss of consciousness. The breathing can stop, they can have an apneic episode, and it's followed by 1 to 2 minutes of that jerking phase, the clonic phase, and they can have irregular breathing. Oftentimes cyanosis accompanies this period. They can bite their cheek or their tongue. They can become incontinent. And then during the post-ictal phase, or the phase after the seizure, they have a period of confusion and sleepiness. They're usually really, really tired. They can sleep for a good long bit after these seizures. A tonic seizure is sudden loss of consciousness where they have increased muscle tone. They can have autonomic manifestations such as apnea. They can have arrhythmias, again, incontinence, vomiting, and salivate. They can start salivating. These tonic seizures usually last 30 seconds or so. Some of them can last up to a minute or so, but not as long. It's 30 seconds to several minutes in time. Clonic seizures usually last several minutes, and they're characterized by muscles contracting and relaxing. And again, this is a seizure where they only have that clonic period, that jerking. Myoclonic seizures are brief jerking or stiffening of the extremities. They can be both sides of the body or one side of the body, and they usually only last for seconds. And then atonic or akinetic seizures are characterized by a few seconds in which the muscle tone is lost. They just kind of fall out. And this seizure is followed by a period of confusion. Focal seizures used to be called partial seizures, and they involve only one cerebral hemisphere. And they're categorized on whether the patient or the person having the seizure is either aware or not aware of the seizure. So as it sounds, focal aware means that the client is conscious throughout the seizure. They may have a sense of deja vu. They could have a change in heart rate, abnormal flushing, pain or offensive smell. Focal impaired awareness is when they have lip smacking, they can pick at their clothes, they have complete loss of consciousness, they black out for several minutes, and they have amnesia, or they don't remember having had the seizure after it stops. There's a type of seizure which is called an idiopathic seizure, or it's one that just does not fall into the other categories we talked about. And these type of seizures occur for no known reason, and they account for half of all seizure activity. The other seizure category I want you to know about, this is actually a generalized onset seizure, so it involves both hemispheres, and it's called an absence seizure, or it's a non-motor generalized seizure, where the person just has a lapse of awareness. They usually have this blank staring look. They smack their lips. They can have chewing movements. It usually lasts less than 10 seconds. You can actually miss these if you're not paying attention. They're very abrupt and short. They can have fluttering of their eyelids, start blinking. They rub their fingers together in this like hand motions, and it's mostly most common in children. This, you might have heard the term petite mal seizures. That's an old term for these non-motorized generalized absence seizures. I've listed here some risk factors for seizures. Typically in absence seizures we just talked about, there is a genetic predisposition. They tend to run in families. Like I said earlier, they're common in children. Febrile seizures are particularly seen in infants or children less than 2. Somebody's had a head trauma, any type of swelling in their brain or cerebral edema. If someone has been on anti-epileptic drugs and they stop them abruptly. Infection, metabolic disorders such as hypoglycemia or hyponatremia can cause seizures. Exposures to toxins such as carbon monoxide, pesticides, heart disease is a common cause of new onset seizures in older adults. Stroke, most likely to occur within the first 24 hours following a stroke, and that's as a result of the increased cranial pressure, which is the same reason why an infection can cause a seizure. Brain tumor, obviously, if there's a tumor inside the brain, it can initiate a seizure. Hypoxia, again, remember hypoxia is decreased oxygen levels, and if you have decreased oxygen levels in the brain, it can cause a seizure. And then I just talked a little bit about the fluid and electrolyte imbalance with the hyponatremia, but abnormal levels can sometimes cause seizures, and then dehydration that comes with some substance withdrawal can cause seizures as well. I have listed here some triggering factors or some factors that can trigger seizures. Go ahead and read through those.
So when someone is having a seizure, there are certain things that you can do to minimize their potential for injury. So the big goal for your care is to protect the patient from injury. If you're in the hospital and they have medication that is ordered, by all means, we can give that medication. But if the client is in the community or educating the client about seizure care of the patient during a seizure, the biggest thing is protecting them from injury. You want to get them to a private area if you can. So I showed you in the other slide that in the generalized seizures, they can have what's called an aura, or a little, like almost a premonition that they know that this seizure is going to come on. So they may have time to seek privacy. But if that happens, always make sure somebody is with them. We don't want them to seek privacy, go somewhere where there's no one to help them if they need help. But if they are standing, we want to ease them to the floor. If they're in the bed, let's keep them in the bed. place the patient on the side with the head flexed forward. So this is very important because when you flex their head forward, it helps move the tongue forward. One of the major complications of a seizure is the tongue can fall back and in their mouth, and it can occlude their airway. So if you can, we want to place them on their side with their head flexed forward. If they're on the floor, you can put a pillow under their head to protect their head, because they will, or some kind of pad, because with the tonic-clonic seizure, their entire body will be doing jerking movements, so we don't want them to cause a head injury from this seizure. If you're in the hospital and you have suction available, go ahead and clear the secretions from the mouth, but only do that before they get to the point when their jaws start to clench shut. So in the seizures, if the patient's jaw is clenched shut, do not ever insert anything into the mouth, okay? So you never want to insert anything into the mouth. You never want to restrain them. If they have restrictive clothing, you want to loosen that clothing. Like if they have a necktie or a tight belt, you want to try to loosen that so that you can prevent injury. In the hospitals, I think the next slide might have a better picture, but there's something called seizure precautions. So seizure precautions with a client that is known to have seizures and is in the hospital will include having suction ready and available at the bedside, having oxygen ready and available at the bedside, padding the side rails. If a patient is in the bed and they start to have a seizure, you want to raise those side rails that are hopefully padded, remove the pillow or any other blankets from the bed, because you don't want them to jerk. They'll be jerking and moving around, so you don't want anything to come in, impact their airway. And then you document, and that's in the next couple slides. For us visual learners, this is a great picture showing the plan of care for a client experiencing a seizure. As I spoke about in the previous slide, you want to have their side rails padded and up. You want to have oxygen and suction apparatus available. You want to put them in the lowest position. So lower the bed all the way down as low as it'll go. Make sure the side rails are up and padded. Provide them privacy. And then when they are in that post-seizure time, make sure that they are lying on their side in case they were to vomit. It looks to me here like there are no pillows or clothing or blankets that could potentially suffocate this person, and they have loosened the clothing as well. The time period after a seizure takes place is called the post-ictal phase. Your care for the client after the seizure has taken place in this post-ictal phase will be focused on keeping him or her safe and maintain a patent airway. So you will want to place them on one side to prevent aspiration. You're going to want to facilitate any drainage of the oral secretions, so you may need to suction them. You will want to check their vital signs. You're going to want to perform neurological checks. You're going to want to assess them for injuries to see if they had injured themselves during the seizure. The client will need more than likely to be reoriented to the environment, because a lot of times in this stage they are very confused. They may become agitated. They may be extremely sleepy. It takes a lot out of them, these seizures. They may be apneic, which means they are not breathing, or they may need supplemental oxygen because they're having issues with gas exchange at this point. Your big interventions would be to keep their airway open and keep them safe. You may need to use gentle persuasion. You never want to restrain the client, but if they're extremely agitated, you're going to want to use some gentle words to get them to remain calm. So if the seizure is witnessed, we want to make sure that we document everything that we are witnessing, that we're observing. So what were the sequence events? When did it start? Did they scream out before it happened? Did they fall to the floor? What was going on prior to the seizure starting? Sometimes they might have what's called an aura, which is, it's described as a warning that sometimes people that have epilepsy or frequent seizures, and we'll talk about that in a minute, what they feel just prior to that seizure. So whether it's lights flashing or some kind of visual disturbance, some kind of warning that it's going to happen. So if that happened, we need, obviously you will need to wait for till they're aware enough to let you know that. You want to document what type of movements they're having. So again, remember with the tonic-clonic seizures, you're going to have that that tonic period is the stiffening of the muscles, and the clonic period is when did I say that wrong? Yeah, clonic period is when they start jerking, they have rhythmic jerking of the extremities. So you're going to want to document how long they did either one of those activities. If you're able to look at their pupils while it's going on, what are their pupils, how are their pupils responding to light? If their eyes or head are turned to one side, if they involuntarily do that, not did you, or even if you did, we want to document that. The duration of each phase, like I just talked about, the tonic-clonic phase, usually the tonic phase only lasts a few seconds, and that clonic episode, that clonic phase lasts longer. So you want to make sure you're documenting everything that you see at the end of the seizure. What type of movements were they doing? What type of cognitive status were they completely aware? Did they have that amnesia? Were they incontinent? That type of thing. So you want to make sure you document anything that you observe during the seizure. Epilepsy is a group of syndromes characterized by unprovoked reoccurring seizures. It affects about 3% of the people worldwide. Your book will say that most forms of epilepsy occur in children and older adults, and that there are more than 1 million American women that have epilepsy. Epilepsy is classified by specific patterns of clinical features. So it's classified by how old they were when they started having these seizures. Do they have a family history? What type of seizures are they? My sister-in-law actually was diagnosed with epilepsy when she was a child. She has since she's grown out of it, so she has resolved epilepsy. But primary epilepsy is considered idiopathic, and what that means is they don't know what's causing it. Secondary, the cause is known, and there's an underlying condition, whether that be a brain tumor or whatever it is that's causing it. But to be clear, epilepsy is the type of, or that's the disease. That's the disease that's associated with the spontaneous reoccurring seizures, and a seizure is the event. If you just have one, if your client just has one seizure and they don't have these recurring spontaneous seizures, they don't meet the other criteria, then they don't have epilepsy. They're a person with seizures. So clinical management or treatment of epilepsy, there are two categories, if you will: pharmacologic or medication therapy, and then surgical management. The goal is to achieve seizure control with as minimal side effects as we can do it. A lot of medications that are anti-epileptic have some serious side effects and some serious issues with toxicity. So we want to be really tight and monitoring, the physician does, with what they prescribe. The medications do not cure the seizures, they only control them. There are specific medications based on the type of seizure and how effective they are to that seizure. Again, I already said severe, a lot of side effects with the anti-epileptics, and the patient can be toxic on them. Up to 80% of the seizures that it can, so the medication can be effective for up to 80% of the people if they're prescribed and taken properly. And then usually the physicians, the healthcare providers will start them on one medication, and if that's not working, they can take them off of that or add an additional one and adjust it as needed. With surgical management, obviously, if the seizures are caused by tumors or abscesses or things in the brain that we can surgically go in and excise, not we, the surgeons can go in and excise, that can hopefully, once they take that out, hopefully prevent seizures. And then there are some additional surgery therapies that are being tested where they can actually go in and identify what part of the brain is having that abnormal firing of the neurons, but we won't go into too much detail on the rest on those because they're pretty much being tested all the time. But typically epilepsy is going to be handled or managed with medication. Status epilepticus is a repeated seizure activity within a 30-minute time frame or a single prolonged seizure lasting more than 5 minutes. This is definitely a medical emergency. There are complications associated with this condition that are related to decreased oxygen levels, inability of the brain to return to normal functioning, and that continued assault on the neurons and the tissues that the neurons are, the tissue of the brain. It requires immediate treatment to prevent both permanent loss of brain function and death. Maintaining a patent airway and proper oxygenations are going to be your priorities. You will want to make sure that you establish IV access, you perform EKG monitoring to watch the heart and the rhythms, monitor pulse oximetry and ABG results. Oftentimes these clients will be able to stop those seizures by administering medication via IV, so Valium, Ativan, Phosphentolin, those can all be given IV. I have given in the hospital Valium rectally, which has also been successful in stopping these status epilepticus. You're going to want to monitor those for imbalances of electrolytes and their glucose level as well as their drug level that the medications they might be taking for the anti-epileptics. And then continuously monitor their vital signs, their neurostatus, the respiratory status, and cardiac assessment. And then you will make sure that you'll follow up all the nursing management pieces that we talked about earlier with just one seizure also apply in keeping that patient safe and minimizing the injury to the patient.
Within the concept of intracranial regulation, we have the exemplar of headaches.
Cephalgia is the formal term for headaches. It's one of the most common physical complaints. Headaches can be either acute or chronic. They can be temporary or life-threatening. Headaches are a common occurrence and affect individuals of all ages. They are associated with other conditions such as colds, allergies, stress, or muscle tension. And they're classified as primary headaches that have no identifiable organic cause. That primary headaches includes migraines, tension headache, and cluster headaches. And the other category is secondary headaches, and those are associated with an organic cause, such as a brain tumor, aneurysm. They warrant further investigation and medical management. So we're going to talk about all of these in the next couple slides. Headaches may cause a significant discomfort for people and can interfere with activities of daily life and lifestyles. I have a very good friend who has migraines, and when she has a migraine coming on, it completely shuts her down, and she has to get out of all of sensory stimulating things and go in a dark room. But we'll talk about that more in a minute. Sinus headaches are pain over the sinuses. They're typically deep, constant throbbing pain, like a type of pressure, and occur after an upper respiratory illness. A cluster headache is localized to the eye or the temporal region, and it's characterized as more of a sudden stabbing pain. It's more common in young men, can occur at night or late evening, and is associated with alcohol use and is a vascular disturbance. So it's where the vessels dilate in the head and cause the pain in the head. Tension headache is usually in the front. It's in the frontal, temporal, or occipital areas. It's dull, tight, and a diffuse aching. It is associated with stress and anxiety or depression. The tension headache is the most common type. And then the migraine. The migraine is, you can have a migraine with aura and you can have a migraine without aura, but it's a complex headache that has a lot of different symptoms depending on the individual. It usually affects one side of the face, and the client can experience vertigo, which is dizziness, or tinnitus, which is ringing in the ears. There can be numbness or tingling in the fingers or toes. Can be triggered by emotions, by different foods or odors. It's a throbbing pain that usually has nausea and vomiting, and photophobia and phonophobia, which is sensitivity to light and sound, can last up to days, and often can have an impact in the activity of daily living up to from 4 to 72 hours. It also is a vascular disturbance, so it is the vessels in the head are dilating and causes the pain in the head, and the migraines are more common in women.
So migraines with aura include these stages. So the prodromal stage includes the awareness of findings for hours to days before the onset of the migraine. So it's characterized by irritability. The person who's having this migraine can have food cravings. They can either have diarrhea or constipation. They can have frequent urination and irritability. Then you have the aura stage that develops over minutes to an hour, and it's characterized by numbness and tingling of the mouth, lips, face, or hands. There can be acute confusion and visual disturbances such as light flashes or seeing bright spots. The second stage of a migraine with an aura is where that incapacitating period happens. There's a throbbing headache that intensifies over several hours. Oftentimes the person has nausea and vomiting. They can have vertigo or drowsiness. The third stage is 4 to 72 hours, and that's when the headache is characterized as a dull feeling. And then the recovery period is when the aura, it's recovery with pain and aura is subsiding. There's muscle aches, contraction of the head and neck muscles are often very common, and physical activity will worsen the pain, and the client will need and want to sleep. In the older adult, the clients can experience an aura without pain, and it's referred to as a visual migraine. Migraines without aura are characterized by unilateral pulsating pain. They, again, can also have that photophobia, which is pain with the light, phonophobia, the pain with the sound or noise, nausea and vomiting, can persist from 4 to 72 hours, often occurs in early morning, during periods of stress, around the menstrual cycle, and the people can have fluid retention, and physical activity. The pain is aggravated by physical activity rather than relieved. Here's a picture of where the pain in the head, the ache in the head, will manifest in the sinus tension, migraine, or cluster headaches. Clients need to be instructed to keep a diary to record the patterns and the triggers when their headaches are coming on. Oftentimes things such as change in weather, foods with tyramine, MSG, nitrates, preservatives, those types of foods can be pickles, aged cheese, artificial sweeteners, beer, wine, caffeine, pickles. Those are typical triggers of headaches. So the client education would revolve around trying to avoid those triggers. They need to report any changes in their headaches that bring on new visual or neurological disturbances, or if they're getting worse, need to notify their physician. Something that they can do to help alleviate the headaches might be remaining in a cool, dark, quiet environment. Sometimes elevating the head of the bed can help. Teaching the clients to manage their anger or handling conflict, getting adequate rest and sleep. Relaxation techniques, and we're going to talk about that on the next slide, but those are important to educate our clients on. If the triggers of the headaches revolve around or involve scents or smells like perfumes, they need to avoid that, avoid tobacco smoke. If their headache is triggered by lights or glare, they need to be taught to avoid those, or to wear sunglasses to reduce that light and glare. There are medications, obviously, that you can use for headaches, and you'll go over those in your pharmacology class, but I wanted to add in here a slide about complementary and alternative therapies to manage headaches. Things such as yoga, meditation, Tai Chi, sometimes people exercising can help these headaches, biofeedback, massage. There are things such as acupuncture and acupressure therapy, things that promote relaxation and alleviate muscle tension. There's also a thing that is called an external trigeminal nerve stimulator, and it's a headband that stimulates the trigeminal nerve, and this is typically used for migraine headaches. So it's associated when the trigeminal nerve is associated with the migraine attacks or pain. So using these can reduce comfort or discomfort, but you want to make sure you educate the patient to not use these more than 20 minutes a day at a time.